thought I was debating Dr. Sweta and I brought appropriate boxing gloves, but I didn't realize even the chairpersons are debating against me. Just pulling your leg. This is a rapidly changing field, and shortage of time, if I were to ask for a show of hands, I suspect there will be more people starting to do plasma exchange in their own centers than offering LDLT in India. We know that LDLT happens more in India compared to cadaveric liver transplant, but there just is not simply enough for the number of patients with this serious problem. So increasingly, people are doing plasma exchange. Now, so it's a rapidly changing field with the realities that we face in India. So the topic which I'm boxing is with Shweta and with Dr. Sethu Babu, I guess, is Plex is better than CRRT. Let me get into the topic. So, as we know, the people staying in the slums around Mumbai airport can only dream of getting onto the flight. It's highly unlikely their entire life they'll get onto a flight. There are just not enough urgent liver transplants for the patients with acute liver failure in India. That's a ground reality. In fact, even in this learned audience, some of us may not be aware of that. So, these two treatments being debated today, plasma exchange and CRRT, are treatments to cleanse the blood, or to be more specifically, to cleanse the plasma in patients with acute liver failure. So I would like to go through them through these different headings. One is, how are these two treatments different? So plasma exchange is removal of plasma from the body, that is plasmapheresis, and replacing the fluid. These two components together is called plasma exchange, and in liver failure, fresh frozen plasma is the preferred fluid. Now, plasma exchange can be done in two ways. One is centrifugal plasma exchange, which is what is done when we donate blood in the blood bank. The blood is separated into plasma and cells by a centrifuge. And I'd like you to pay attention on the flow rate. The flow rate, the rate of flow of the plasma in this process, or the blood in the plasma process, is 30 to 50 ml per minute by the centrifugal technique. And we believe this is the preferred technique of plasma exchange in liver failure for the flow rate being low. There are different volumes of plasma which have been used in plasma exchange in liver failure. Again, for lack of time, I'm not going into details. To treat liver failure, high, standard, and low volume plasma exchange have been used. At CMC Vellore, we have been majoring on the use of low volume plasma exchange. In contrast, CRRT, continuous renal replacement therapy, the flow rates are higher. So the lowest flow rates are in the range of 125 to 150 ml per minute. And we believe that that is not so good in this clinical scenario. There are different forms of CRRT possible: hemofiltration, hemodialysis, and hemodiafiltration. So to confuse things further, or to understand it better, plasma exchange can also be done with the CRRT machine. So that is called the membrane type of plasma exchange. So there are two forms of plasma exchange possible. One is a centrifugal plasma exchange machine, which usually is more familiar to the blood bank doctors, so transfusion medicine doctors, while the membrane filter or the membrane plex is more often in the nephrologist domain. And I think intensivists like Shweta will be familiar with both centrifugal and membrane as well. So there are different technologies available for these. Now, there are not enough trials comparing centrifugal and membrane. However, this is the study, I believe, which throws some light on it. This is our data set, and Santosh Kumar in the audience has analyzed this data. This is not acute liver failure. These are patients with very severe alcoholic hepatitis. And by definitions, all of them would fit with the APASL ACLF criteria for ACLF. And majority would, or proportion, 50% or more, would have met the ESL ACLF criteria. So in this sick group of patients, centrifugal plasma exchange clearly improves survival compared to standard medical therapy and compared to membrane plex. So we have moved to the use of only centrifugal plex in treating liver failure. In most centers in India handling bigger numbers of plex, they all are using centrifugal plex is what I've understood from personal discussion with various teams. Given at the bottom is the flow rates. In centrifugal, the flow rate is, in this particular study, was much less than the flow rate using the the membrane plasma exchange. Now, CRRT removes molecules which are dialysable, which are usually less than 60 kilodaltons in size, like ammonia, while plasma exchange removes the entire plasma. So any molecular weight is removed, so thereby macromolecules, and we believe that is the reason why there is a survival benefit with PLEX, is the removal of these macromolecules. So CRRT is aimed at, as of now, we are aiming more to say ammonia reduction and thereby reducing cerebral edema in ALF. While in PLEX, it seems to be having an anti-inflammatory role and recovery of liver function. So the liver sinusoids are in a state of acute inflammation, are like a traffic jam, which we face in all cities all over the world. It's a transient phenomenon, but it can result in perfusion abnormalities and cause hepatocyte necrosis and death of the patient, potentially reversible. A team which delivers PLEX to treat ALF comprises of two groups of doctors. It's good to know that. The one is a clinical team, and second is an apheresis team. The clinical team decides on which patient to do PLEX, when to start, when to stop PLEX, counseling the patient, prescribing the dose. Literally, one has to prescribe the dose of PLEX, the type of PLEX, and assess daily clinical response. While the apheresis team delivers the PLEX. Now, do these treatments improve survival in ALF? The answer is a clear yes. There is enough data now to show that both these treatments improve survival. So this is the randomized controlled trial, Larsen et al. From 3 European countries, showing survival benefit in a cohort where maximum patients had paracetamol overdose as a cause of ALF, while Raki Maiwal from ILBS has shown in this report of this randomized controlled trial, where the majority of patients had viral hepatitis causing acute liver failure. So based on this, the American Society for Apheresis, way back in 2019, has declared that high volume plasma exchange could be a standalone treatment for treatment of acute liver failure. Now, what about CRRT? Again, the answer is yes. The data is from matched cohort studies, retrospective studies from USA, as well as from Australia and New Zealand. Again, it shows survival benefit compared to no CRRT in patients with ALF. Now there are meta-analysis now. This is from our center, where we looked at the use of PLEX with the current RCTs and matched cohort studies, again, which shows that PLEX is safe and improves survival in patients with ALF. Meta-analysis with CRRT again shows that it is good, it improves survival in ALF. So to tabulate that together, the current data is RCTs, there are 2 of them, have shown survival benefit, transplant-free survival benefit with PLEX over standard medical therapy. There are no RCTs in CRRT as yet. There are retrospective study, cohort studies for both, and there is meta-analysis showing. In fact, the patient numbers in meta-analysis are also similar. In PLEX, there were 265 patients in the PLEX arm compared to the SMT. In the CRRT meta-analysis, is 305. So it's almost similar. Now, which patient should we then offer this treatment? This is now a matter of opinion, and I'll state my point of view. So in this paper, Ashish Goel has looked at, does the nation have predominantly a cadaveric program or an LDLT program? In India, where it's predominantly LDLT, are we living in India or in Bharat? Most of the government medical college hospitals are in Bharat, where there is no access to urgent liver transplantation, which is the majority of India, not the minority. The minority is where there is access to LDLT. So again, the slots that we take in this dangerous clinical scenario, the options that are taken depend on these realities. So we had brought out an algorithm suggesting, should we do PLEX or oh well, I've added on CRRT now. The article was only on Plex. So in a patient with ALF in India, if there's an option of liver transplantation, that is LDLT mostly, answer is clear, yes, we should opt for that. But if there is no option of urgent LDLT, which is majority of patients in India, then what else can we do apart from SMT? So then the question of consider plasma exchange. However, in this article, then we thought less severe disease would respond to this sort of treatments. Why not then do it in severe ALI? So in a person with severe ALI, we say the choice is not, first choice is not urgent transplant. First choice is then Plex. So that's what we have said. So in that case, CRRT wouldn't figure as of now. So it is more in severe ALI, I would say, of the two, it's for Plex. Vijay Alexander has analyzed our data set and shown that patients who are not ventilated liver failure patients are at a low risk of getting severe complications like which are related to transfusions. A lot of plasma is transfused during these treatments, and there are possibility of uncommon lung complications which can be fatal. So TACO and TRALI in this data set are uncommon in the non-ventilated patients. To say it another way, this is a nice window to treat these patients. A person who is not ventilated and earlier in this illness of ALF or severe ALI, this sort of complications are very, very less. So then let's put it together and say what are the indications. If a person has got a severe, what is called a renal indication of CRRT, that is treatments, medical condition situations not responding to medical therapy like hyperkalemia, acidosis, pulmonary edema, answer is dialysis, that is CRRT is the answer there in the sick patients. But those who do not have those indications, they are called non-renal indications. For example, reduction of ammonia, one could use CRRT. Now, Plex is considered not for the renal indications. Plex is considered, as I said, it's all a work in progress as an anti-inflammatory effect. It also, and the studies reported, has ammonia reduction effect as well. There's a choice of doing both CRRT and Plex as well. But because of the logistics, etc., it's less commonly done. Yet another way of looking at this data set, at this scenario, let's look at the clinical syndromes. In patients with acute liver failure, one can opt for either CRRT or Plex or both. What about a patient with severe acute liver injury? If you wanted to opt for these, maybe the answer is it's Plex, it is not CRRT. What about ACLF? I briefly touched upon severe alcoholic hepatitis. There the answer is Plex, it is not CRRT in that scenario. So lastly, I'm moving on to, I'll have to overshoot by a few minutes, looking at using the example of rodenticide ingestion, that is phosphorus containing rat poison, as a cause of liver damage in Tamil Nadu to illustrate this point. Now, criteria derived reported from Amrita Hospital, Kochi, we are currently calling the Kochi criteria, 9 years ago. From their data set showed that patients who met these numbers, MELD more than 36, and an INR and encephalopathy, these numbers, was what they said, they in their data set suggested they needed, without urgent transplant, the person doesn't survive. So using that, let's look at the data set at CMC Vellore first. Now we have analyzed in this paper which just come out by Vijay of 200 patients with rodenticidal hepatotoxicity, 114 underwent Plex, of whom 57 had acute liver failure and 51 had severe acute liver injury. The 1 month survival in those who were Plex eligible, that means they did not have contraindications for Plex and met Kochi criteria, in the ALF patients was 56%, and in the severe ALI was 100%. 65% of the patients were not treated in the ICU. So increasingly, In the group, when you were treating it earlier, we are treating more in the ward in a monitored area. In the first paper from Amrita Kochi, what we call the Kochi criteria, of the patients who met these criteria of severe disease, those who underwent liver transplantation, the survival was 86%. Of the 8 patients who did not undergo liver transplantation, survival was nil. None survived. In our data set, of the 32 patients who met those criteria and were PLEX eligible, the survival is now 69%. So it appears there is increasing survival, but always the first choice is urgent liver transplantation. Now, this important study from the Tamil Nadu chapter of ISG, conducted in 2019, showed that of 450 patients, 1/3 died. This is the reality in India in 2019 data, and only 1 patient underwent urgent liver transplantation. So in response, the TNISG brought out guidelines of use of PLEX, which remains, as of now, the world's only guidelines in ALF. But of course, they're not guidelines for ALF, these are guidelines for treating rodenticide poison. And it says, the guideline states that for patients with INR of 4 or above, or serial worsening INR, that means there only be severe acute liver injury, is proposed that PLEX can be done. And with any encephalopathy, that is ALF, PLEX to be done. Now, I added on CRRT now for this debate. CRRT is not part of the guidelines, but CRRT is also an equally good option as well. So, this has now been implemented by the government of Tamil Nadu, across Tamil Nadu. And there are 32 districts in Tamil Nadu. In each district government medical college hospital, there is now provision to do PLEX. It's not yet in each district. About half the number of districts have it. And in these 2 years, 2022 to 23, 1,200 odd patients underwent PLEX by this government scheme. So the denominator must be much bigger. That number is not out. These are only those who met PLEX criteria by this indication that underwent treatment. In the same time period, in the 2 years, across Tamil Nadu, 3 patients underwent cadaveric liver transplantation, which is the Bharat that I'm referring to, which is most of India. So, in our milieu, looks like PLEX is more implementable. This is the last slide. So, I would like to highlight the PLEX team again. So, in this Tamil Nadu District Government Medical College Hospital, the clinical team which prescribes the treatment is usually medicine department, and in some places it's gastroenterology or hepatology. And the apheresis team is transfusion medicine, and most of the patients are not in ICU. In fact, I think none are in ICU. They're all in a highly monitored area. So I think I will stop there. Thank you.